Good evening and good morning to one and all who have been here for this fifth Journal Club meeting of Journal of Hand Microsurgery. Indeed, we're really happy and privileged to have three very important panelists here. Dr. John FOWLER, Dr. ASIF, Dr. Peter TANG. These are the, I call pioneers because I used to read all those articles about nerve injuries associated with humerus fractures. We are also very much, thankful to Dr. ASIF, who swiftly responded to say that, yes, we will do it. The moment I send him an email, that much is his commitment towards academics. I know him personally also, and also he is a well-wisher of Journal of Hand Microsurgery. With this brief introduction, we will go to the first talk by Dr. John, who is going to speak about the fractures of humerus associated with nerve injuries.
Thanks a lot for the introduction. I'm honored to be here. I work at the Children's Hospital of Pittsburgh, and so we do see a fair number of nerve injuries after supracondylar fractures. So, as all of you know already, the supracondylar humerus fracture is the most common fracture in pediatric elbows. The most common ages are 4 to 6, and most are extension type. And interestingly, the left side is more common than the right. Here is that in picture form, showing that at least in the United States, the kind of the largest group is ages 3 to 6, and then it tails off after that. And it's not that older kids don't get elbow injuries, just they don't tend to get the supracondylars that the younger kids do. And as probably most of you know, a lot of these fractures go along with the season. So in the United States, the April through September, October is kind of the prime kids outside playing on jungle gyms and monkey bars. And so we see more of these in the warmer months, and I'm sure you see the same in your own countries as well. So, the question always is which nerve is classically affected, and it does depend mostly on the type of fracture and where the distal fragment goes. So in general, extension type injuries tend to involve the AIN and also the median nerve. Flexion type is almost always the ulnar nerve, and then you can get some of these other extension variants with the posterior lateral fracture, posterior medial fracture. And that's not to say that you can't get an AIN injury with a flexion injury, but these are just the more common types. And the picture on the right side kind of demonstrates why the median nerve is more injured with the extension types, because the nerve can get tethered and then stretched as the distal fragment extends. If you look at some of the data, I'm going to present that in a second, the incidence of nerve injury with supracondylar humerus fractures ranges from 7 to 16%. As I said before, the AIN is the most common, radial nerve is the second most common, and as I said before, flexion types are almost all ulnar nerves, but in general, flexion type supracondylar humerus fractures are much more rare. So even though, as we'll see, the ulnar nerve is very affected in flexion type supracondylars, overall those are a smaller portion of the cases. And I think, as most of you probably recognize, the hard part about kids is they don't always follow the exam very well. Sometimes they're in a lot of pain, they're anxious, they may not be able to do a good nerve exam, so you can't always tell what's in, what's out prior to surgery. And I think sometimes in my review for this talk, there's a lot of quote-unquote iatrogenic injuries, or times where there seemed to be the nerve was intact before the surgery and now is out afterwards. And I do think it is hard to know, was the child just not participating well in the exam, or was the nerve really in before and out after? But I think it's important to do our best to document a good pre-manipulation or preoperative exam so we know if our manipulation or our intervention changed the neurovascular status. So why the AIN? I mentioned this earlier in that picture, but we think it's a traction injury. The AIN is in a relatively fixed position in proportion to the radius and ulna, and so it can get tethered on the Ganser's muscle. There's some ulnar collateral vessels that are sometimes described. There can be an accessory muscle from the FDS to the FPL, and then we think maybe the deep fibrous head of the peroneal arteries can be involved as well. So I'm going to go through some of the data that's out there. Even though I just mentioned that these nerve injuries happen in 7 to 16% of supracondylar humerus fractures, at least in my experience, I seem to only really get involved in the ones that don't recover quickly. So some that you get some transient palsies, a lot of times the pediatric surgeons at Children's where I work don't even give me a call. They really kind of wait until it seems like it's lingering. So here's a study, retrospective review of 200 type 3 supracondylar fractures. So these are the very displaced ones in kids 2 to 18. There were 19 nerve injuries, so again, 9.5%. And you can see the breakdown. AIN was most common, which again would make sense with the extension type. So of those 19, 11 of the 19 involved the median nerve. Here's a really big meta-analysis, 5,100 fractures. The nerve palsy in about 11%. And it kind of matches the data I presented earlier that the AIN is the most common in extension type. If you add in the median nerve proper, that goes up to over 50%. And then in the flexion types, the ulnar nerve is most involved. Little pictorial representation down on the bottom. It is interesting when you look at the extension type, radial nerve was actually fairly common in that group too. And I think most of the time we tend to think of these more median or AIN injuries, but radial actually was more than median nerve proper. And then here's the one series I kind of mentioned showing that ulnar nerve is the most common with supracondylar flexion types. And you can see in this series of over 1,000 fractures, there were only 23 flexion types, just showing the more rarity of those. Displacement seems like it matters. We talked about tethering and things like that. So in these 6 nerve palsies out of 23 that were ulnar, 5 out of the 6 were type 3 fractures. And the good news, at least in this series, all of them involved with reduction and then pinning of the fracture. Again, another big series out of JBJS, one of our big journals, which looked at a really large number, 2,700 supracondylar humerus fractures at one institution, which was the Children's Hospital of Philadelphia. They had a 3% rate of flexion type injuries, and you can see the ulnar nerve was injured in about 10% of those. They looked at their data and found there was actually a 15-fold higher rate of need for open reduction, and that may point to maybe sometimes in these flexion types, either the nerve or the artery or something is getting tethered in the fracture site. It can prevent inadequate closed reduction and pinning. So we've talked about the incidence and how often these occur and which nerves tend to be more involved in different fracture types. So we know that the more displacement of the fracture there is, the higher the rate of nerve injury. So obviously type 3 fractures with a lot of displacement are going to have more nerve injuries in general than type 1 or even type 2 fractures. Are there any other clues we have to maybe something that would have a higher risk of nerve injury? Well, one of the things we see is elbow swelling, and that makes sense, and that might even correlate with increased displacement. Those will likely be more swollen than a minimally displaced fracture. This picture over here is showing some skin abrasions with severe swelling. We also think that puckering, skin tenting, and then the next slide shows some of this puckering and then antecubital fossa ecchymosis. And that would be maybe a marker or maybe a clue to this person or this child has a higher risk of nerve injury just based on some of those physical exam findings. So one of the frustrating things with a lot of the recommendations that are out there is that most of them end up being inconclusive just because there's not a lot of good prospective data. It's usually pretty low evidence. Almost all of those series I presented for the data about incidence and nerve injuries are almost all retrospective series or kind of a low quality meta-analysis. So when our AAOS Academy made recommendations on treatment, they say they're unable to recommend optimal timing or indications for nerve testing or nerve exploration. And I think unfortunately that's kind of the way some of these things go, where there's no good recommendation. So here's a good question: is nerve exploration indicated, and when? This study looked at 272 displaced supracondylar humerus fractures, so types 2 and types 3. They found the nerve injuries were 18%. Now, interestingly, if you kind of look at the data I present there, they say that only 3% of those were on admission and 14% were after treatment, and a lot of those were ulnar nerve kind of temporary transient palsies, which seems like after putting in a medial pin. But the good news in this series that all of the nerve injuries resolved clinically at some point, and on average they resolved in about 3.5 months. So this study would say, well, all things being equal, maybe we don't need to or shouldn't be exploring these nerves early on because it does seem like a lot of them do recover. What about the pink pulseless hand? And I think this isn't a talk about should we be exploring the artery or doing a revascularization, but what do you do in the pink pulseless hand? Because as we all know, the median nerve runs right next to the brachial artery. So if you have an injury to the brachial artery, it makes sense that you probably have an injury to the median nerve. And is that artery and nerve potentially trapped in the fracture site? So what do you do if you have a pink pulseless hand? That's kind of a debatable. This paper here, which was in 2013, said if that's present, maybe you should consider exploration because it could be trapped. With that said, another big series here of these, not a big series overall, but 71 patients that have a pulseless hand and an AIN nerve injury, what do you do about those? So they had 52 that actually underwent closed reduction and percutaneous pinning. And they said that of that group, 50 out of 52 were quote unquote successful, meaning that they didn't have to do anything more than that. I think in the group that got open reduction, you can see 6 of the 19 required vascular repair. So if you have a nerve injury in a pulseless hand and you do the reduction and now you have a pink pulseless hand, I think in this series they ended up watching a lot of those. But for the ones that they couldn't get reduced or they continued to have a pulseless hand that maybe wasn't pink, they explored those. And you can see kind of on the right-hand column over here that the median nerve was the most commonly injured in this series at least, but only 6 of those were isolated. You can see the AIN was the one that's more commonly an isolated finding. And again, the good news for these is of this group that didn't require like any grafting or nerve repairs, 59 of the 61 that they had follow-up on recovered full function at long-term follow-up. Now, most of these were at least 3 months. Sometimes they took 6 to 9 months to fully recover. The other question that we get asked is, what about timing? So, a lot of times, at least in my institution, someone comes in at 10 p.m. or even 6 p.m. the day before with a supracondylar humerus fracture. A lot of times those kids are made NPO, kept overnight, and then the very next first case in the morning, 5:30, 6 a.m. start. The question is, if they have an associated nerve palsy, should that child have surgery sooner than if they didn't? And this study looked at, again, a really large series, and they found really no difference in time to the OR if they had an AI injury or not. And the good news is that regardless of whether or not they had an injury or not, in time to the OR, 90% of these patients recovered by 150 days. And you can see that in general, most of them recovered in about 2 months. And this slide here just kind of shows actually the kids with some of those skin findings we had before, like the antecubital fossa ecchymosis, actually took longer to get to the OR, which is kind of surprising. But you can see there's really no difference in time to recovery. So that in general, obviously there's always exceptions to every rule, but in general, we shouldn't feel like we have to rush these nerve palsies to the OR because if we don't, they somehow won't do well postoperatively. Well, how about outcomes? So nice long-term follow-up study. You can see here we've got those kids coming back at 8.6 years. And in general, the radial and median nerve injuries recovered. They didn't have any long-term sequelae from that. But interestingly, in this series, those flexion types with the ulnar nerve injuries, despite having pretty good motor function, a lot of them had paresthesias on the ulnar side. And I think that all of us that do kind of ulnar nerve surgery, either in kids or adults, know that the ulnar nerve just doesn't recover quite as fast or as well as maybe even the radial nerve or the median nerve. So that may make some sense. Here's another one looking at the extension type injuries. Again, just like we said earlier, 7 to 16% is kind of the rate. In this series was 11%. You can see a lot of them in this series had concurrent vascular injuries. So I would say this is, definitely like a higher acuity because 30% of their patients had vascular injuries. A lot of them were median nerve. And again, median time to recovery, 2.5 months, and about 60% recovered by 3 months. And then a lot of them recovered later than that. If you look at the table over on the right, you can see that some took more than 6 months, about 10% to recover. Here's a study out of Africa. They actually had a pretty high rate of iatrogenic, meaning after the surgery, people had ulnar nerve palsies. And basically what they said is that all of the nerve palsies associated with surgery, so intact exam before, different exam after, they all recovered. So the recommendation from this study was don't explore. And then the 2 combined injuries did not. I think this was kind of my last slide here. Again, supracondylar humerus fractures, type 3. You can see the nerve injuries, vascular injuries, and a final follow-up quick dash of 11, which is basically kind of in the normal range. And I'll skip through that. Mean time to recovery, 122 days. All right, so in general, or in summary, I would say routine exploration of most of these nerve palsies is not indicated. The ulnar nerve may be an exception based on some of the data in these supracondylar flexion types. If vascular repair is required, I would say you should probably explore the nerve at the same time as either you or the vascular surgeons are working on that. We should expect spontaneous recovery of these nerves around 2 to 3 months. And that in general, I don't think there's a good role for early nerve conduction studies in this age group. Thanks for your time.
Thank you, Dr. John. It was really amazing, and you opened up a lot of ideas. Many things that we need to address the ulnar nerve injury or address the ulnar nerve by doing transposition or decompression. And as rightly mentioned, that be cautious and have clear concerns doing ulnar nerve transfer, ulnar nerve decompression associated with humerus fracture. That's fine. We have a lot of questions at the end. We'll keep questions at the end. Thanks for a wonderful talk.
Thank you.
Thanks. We have Dr. G. Karthikeyan. He's a professor there in Department of Plastic Surgery. He's one of the pioneer, and in fact, he's a teacher. He's with us. Sir, can you share your thoughts and comments on this speaker?
you opened up a new, different lines of thought. Now, my only question was, we usually come across compartment syndrome in these patients with supracondylar fracture. How many patients have been reported in literature with compartment syndrome, and what was the nerve injury after compartment syndrome in these fractures?
Yeah, I mean, clearly it's a higher energy injury. As far as I could tell, I didn't see a lot of published studies on that. And I think the question becomes, was the nerve injured from the compartment syndrome itself that maybe was, I don't want to say missed, but like a delayed kind of compartment release, or was it injured at the time of the actual injury? And I think we may never know for sure. But I think you bring up a great point that especially these cases with neurovascular injuries, and, with vascular compromise, much, much higher risk for compartment syndrome than the non-displaced ones.
Yeah, thank you. Thank you.
Sure.
Thank you, Dr. John Fowler. We have Dr. Arun Geethan here, the surgeon who also does a lot of pioneer works in humerus fractures and neuropathy. Dr. Arun, your comments, and then you can probably introduce the next speaker.
Thanks, John. Wonderful talk. It's quite enlightening to see all the results, and also the fact that we don't have to operate in the middle of the night. It's a bit reassuring. We'll just move on to the next talk because of want of time. And let me introduce you to Dr. Peter Tang, who's a fellowship program director of hand surgery and an associate professor of orthopedic surgery from the Drexel University College of Medicine. He's waiting to give us a talk on ulnar nerve dysfunction and management of distal humerus fractures. Over to you, Dr. Tang.
Peter, you're muted. Start over.
You hear me, Asif? Am I sharing?
We can hear you, but you're not sharing yet.
Okay. Sharing now?
Yep.
Yes.
Okay. All right. All right. Thank you. I'll be talking about ulnar nerve management with distal humerus fractures. I'm mainly at Allegheny General Hospital in Pittsburgh, where Dr. FOWLER is also. So I'll start with a couple of cases to keep it relevant. So this is a 41-year-old gentleman who I met early in my practice, like about 14 years ago. He was dropping into an 8-foot empty pool on a skateboard to show some kids, quote unquote, how it's done. And basically, what he was trying to show them is how to get a very high energy distal humerus fracture that was completely displaced. These are some choice cuts from his CT scan showing comminution and extrusion of his articular surfaces. And so basically we indicated from surgery, and we did a posterior incision with full thickness flaps. And one of the first things I do when I tackle these cases is basically do an ulnar nerve release to get away from the site that we're working at and do full release. In this case, we did an olecranon osteotomy, as we see here being raised. And the ulnar nerve, I usually place a vessel loop without a snap so that if it gets snagged by something, the vessel loop will just fall off and not be tethered by the loop. And so during the case, I'm extremely wary where the nerve is, as drills are crossing the field and being used on the bone. And then basically we fixed his articular surfaces on the back table. And this is us trying to reconstruct his distal humerus. And this was early in my practice, and so I would have done it differently now, but basically I used the recon plates because I thought I needed to get the very correct contouring of distal humerus, but I'm not exactly sure why I didn't use distal humerus plates. And then the ulnar nerve at the end of the case, as I routinely do, is I leave in a sub-Q transposition, which is what I normally do. And this is what the post-op films look like. Again, this is early in my practice, so I probably would use free K wires, which later on work itself out of the bone. And then I give myself probably like a B- because I didn't really restore the fossas, like the corner and the left tip fossa, So they're kind of like compressed there. But this patient did not have any preoperatively or postoperatively ulnar nerve symptoms, even with this very high energy injury. Here's another case, 71-year-old woman who actually just did surgery on yesterday, and I'll tell you about it. She fell 6-7 feet off a scaffold and sustained this fracture, partial articular fracture, or mainly partial articular. She did not have any ulnar nerve symptoms preoperatively, and but after surgery, at her 2-week visit, she started to complain of numbness and burning in the ulnar nerve distribution. At the time, her 2-point discrimination was 5 millimeters. We decided to watch it. She underwent her surgery, and then during her surgery, I did another ulnar nerve release, again, left in a sub-Q transposition. And usually, sometimes at the end of the case, when I'm kind of tired after this Humerus fracture, I'll just suture the sub-Q fat to the medial epicondyle, and the nerve didn't really look contused. At 10 weeks, she was still complaining about numbness and tingling and burning, and then she was developing a non-union. And so I talked to her about doing something with her ulnar nerve. So at that 10-week visit, she had developed intrinsic wasting, a Frohman sign, and a Warburg sign. But surprisingly, her 2-point discrimination remained intact. She had good range of motion of her elbow, which I'll show you here. Bend it all the way, straight, bend, straight, good. And this is how her finger abduction. Spread. Hold it real strong on your push. So she has intrinsic wasting, Warburg sign, and ironically, I did surgery on her yesterday, and I talked to her about either doing the just tackling the ulnar nerve with a release, and then working on the non-union at the same time. But we decided together that we would probably give the non-union more time. So basically, the benefit of that was that I could approach the ulnar nerve from the medial side and not have to use about the posterior incision, and obviously have to work my way out to the medial side. And so basically, we opened it up, and there's a large amount of scar throughout the whole nerve, as you can see here. Didn't look, I've seen worse, but there's a fair amount of scar. So it probably could explain some of her motor deficits. Again, surprisingly, her sensory 2-point was intact. So I did a full release. Wasn't the hardest release, fortunately. Yesterday, actually, it was a long OR day and a lot of difficult cases. And I thought this was going to be a difficult case, and it turned out to be the easiest case of the day. So there was a plane between the nerve and the scar, and we did a full release. And basically, I placed a nerve conduit, 3 of them, wrapping the nerve to hopefully prevent scar. And hopefully, this is a different inflammatory state for the elbow. And so hopefully this won't happen again, because it's not in the setting of her distal humerus trauma. And so basically, this time I did a formal fascial dermal sling by lifting up this fascia off the flexor peroneal mass and suturing to the sub-Q fat to keep it in the subcutaneous position. I personally don't believe in some muscular transposition for revision ulnar nerve surgery. I think it's actually a very bad surgery, a lot of trauma. I don't think it actually makes a difference. I think it doesn't really matter where you put the nerve in that situation. I think it matters what you do around the nerve that maybe prevent scar. But position, I don't think. And putting under a flexor peroneal mass, I personally think is a bad idea in general. So basically, the ulnar neuropathy and distal humerus fracture in the literature has been given an incidence of 0 to 51%, so a very large range. And basically, in our literature, it's unclear how to manage the ulnar nerve after distal humerus fracture repair. And to determine the best management has been confounded by multiple potential etiologies of nerve injury, including the initial trauma, iatrogenic during surgery, and/or scar or swelling during the post-op period. Most people advocate that the ulnar nerve is released to facilitate fracture repair and prevent iatrogenic injury. And there are basically, I can go through some of the papers, which there are not a lot of, surprisingly, but basically the literature finds that transposition has either more or less ulnar neuropathy. So basically it's contradictory. And so one of the best papers out there, and not to give Dr. ILYAS undue adulations, is this meta-analysis that he performed on 5 of these studies. Basically, he found that the ulnar neuropathy was 19.3%, and the incidence of neuropathy in the transition group was 23.5% as compared to the in situ group, which is 15.3%. Now, this is a meta-analysis study, so obviously the results basically depend on the quality of studies that went into the analysis. But some of the things are, how was the ulnar nerve handled during the case, and how good were the researchers at really detecting ulnar neuropathy preoperatively. So these are factors that can actually obviously affect the results. So here's some points for discussion. So one thought, there was this current concepts paper by Ring and JBS that talked about why transposition had a higher incidence of neuropathy compared to in situ when they have equivalent outcomes in the pupil tunnel release when compared to distal humerus fractures. However, the important point that's differ in those situations that this is a trauma setting. And in the cubital tunnel scenario, when we talk about in situ release, we're talking about a very minimal dissection of the ulnar nerve by the medial epicondyle. This is the trauma setting, where basically we're doing a full release of the nerve. And then when we say in situ, it means that we're putting the nerve back in its position. And another thought is the ulnar nerve and more at risk in the distal humerus fracture, which kind of would make sense. And most advocate that you do a full ulnar nerve release and transposition, or at least during the duration of the procedure to prevent iatrogenic injury. And then it's a dealer's choice what to do with the nerve afterwards.
It's 8 o'clock.
And one would think that the major insult to the nerve is from the original trauma and or the nerve release. And really the final resting place of the nerve really doesn't matter. And then the other technical difficulty is if you do a full release of the ulnar nerve, then I'm not exactly, and I've never done this before after distal humerus, I'm not sure how you put the nerve back into its position where it was originally. You've done a full release, you release all the fascial tethers on the nerve, and then you want to put it back into its original position, so which sounds like a technical challenge. And so I've never done that, and it doesn't fully make sense to me. Even in the in situ setting, when we do cubital tunnel releases, we talk about doing a transposition where the nerve becomes unstable from that small dissection of the nerve around the medial epicondyle. So I'm not exactly sure how you put the nerve back in this position after a distal humerus fracture occurred. So that's all I have for now. I'll unshare my screen.
Thank you, Dr. Peter Tang. That was very concise and more informative about the nerve, or to do a decompression or just to wait watch. Thank you very much. And speaker, Dr. ASIF, who is supposed to be one of the top doctors in Philadelphia. I'm just going through this, details which he sent to me. It was really nice. I have say about Dr. ASIF because he's a very good surgeon, academician, teacher, and more or less is very young and dynamic. I used to read a lot of his articles about any reviews you take about in Journal of American Orthopedic Surgeons. I used to refer all those articles which are written in the recent. Thank you again for joining us. We would love to hear about the most controversial, which many of the surgeons want to know, especially radial nerve palsy with humerus fractures, when to intervene, when not to intervene. And even as you said, less than 3 weeks surgical time, favorable outcome. So thank you. Let's.
Thank you, Terrence. That was very generous, and I very much appreciate the invitation. Terrence, if you could give me the ability to share, I'll share my screen.
Yeah.
But while we do that, I just want to acknowledge Terrence for organizing these sessions. They're really great, and it's a great opportunity to bring everyone together, frankly, across the world, which is really quite amazing what we can do today, especially in this era of time where it's hard to be around each other on a regular basis. I also want to recognize my co-faculty, Dr. John FOWLER and Dr. Peter Tang. Both are superb surgeons, superb educators, and just great people, great family men, and someone I'm fortunate to call both friends and colleagues. So it's really great to have them with me and with all of us this morning. Terrence asked me to talk about this topic. It's a topic that I enjoy because I think there's some controversy around it, and it's fun to talk about controversial topics generally. There's a lot of things that we do where there's not a lot of controversy, but here I can say there is still a lot of controversy. So it's good to kind of discuss that and kind of talk it through a little bit, and look at the pros and cons and the strengths and the weaknesses of the literature to try to make good decisions. So before we started the talk, people were asking what the weather is like here. Myself, John, and Peter all live in the state of Pennsylvania, which for those who don't know the geography of America, it's in the Northeast, and most folks know New York City. So we are basically just southeast of New York. We're adjacent to New York State, and we're about an hour and a half to 2 hours. Well, I'm an hour and a half, 2 hours from New York City. John and Peter are a little bit further away, but this is what's going on right now in Pennsylvania. It's snowing, which frankly is very beautiful as long as you don't have to go outside or go to work or do much of the shoveling. So I just want to share with you what it's like on our side of the world right now. Here are my disclosures, nothing relevant to today's talk. So let's start with a question. Let's ask ourselves this question. So let's say you are out and you fall and incur this isolated humerus fracture in your dominant arm and present with a wrist drop. How would you want to treat it? And I think this is always the best question to ask, because when I train my residents and fellows, I always tell them, you know the literature better than anyone, definitely better than your patients. So if you're not sure what to recommend, just ask yourself what you would want in the same situation. So would you want immediate nerve exploration or fracture fixation, or would you want to have this specific fracture treated with closed management and observe for radial nerve recovery? If you're in the latter group and you want to treat this non-operatively, how long are you willing to wait for radial nerve recovery to occur? Do you want to wait 3 weeks, 6 weeks, 3 months, 6 months? There's support in the literature for all those periods of time. So what is your threshold? How long are you willing to wait? And let's use that as a backdrop of our discussion today about this problem. Whenever we talk about humerus fractures and radial nerve palsy, we have to acknowledge Holstein and Lewis, who described this condition essentially back in 1963 in a publication in the Journal of Bone and Joint Surgery, where they described the classic presentation of a spiral humerus fracture with an associated radial nerve palsy. And they said this fracture pattern has a high predilection. I think in their series, 5 out of 9 or 6 out of 9 patients had a radial nerve palsy. But we know now today that although that may be the classic pattern of a radial nerve palsy with the humerus fracture, we know that it's not limited to just the distal third, but even middle and distal third fractures of the humerus can potentially have a radial nerve palsy. And why the radial nerve palsy occurs is for a number of reasons. Most commonly, there's probably a traction injury to the nerve at the time of injury. There may be a contusion of the nerve, or there may be an actual laceration, either complete or partial. And the presentation is often like this. So for the sake of our discussion today, we're going to focus on complete radial nerve palsies at presentation in terms of how to manage that. So what do we know about incidence of these injuries? Well, what we do know is that through a number of recent systematic reviews, that the incidence is somewhere around 10 to 12%. This is a well-cited paper we'll talk more about, published in the JBJS European or British in 05, noting 11.8. Another series had 9%, and then we recently did a review as well, and we came up with 12%. We'll talk more about their review momentarily. So I quote typically 10 to 12% incidence of a radial nerve palsy in the setting of a humerus fracture. The real question is when should we treat these injuries non-operatively, and when should we treat them operatively? And the reality is we actually have very limited evidence to guide us to make the right choices. But let's look at the evidence that we do have. So let's specifically look at when should we treat a humerus fracture that doesn't have a radial nerve palsy, so just a regular humerus fracture without a radial nerve palsy. What are our operative indications? What do we recommend to our patients? What do we tell our trainees? Well, if it's an open fracture, there's no controversy. It can be treated operatively. If it's a complex fracture, complex means that it's associated with a soft tissue injury, like a soft tissue, skin envelope, nerve, artery, etc. If it's a pathologic fracture of the humerus, it can be treated operatively. If it's a polytrauma case where there's a humerus fracture and other injuries, such as lower extremity injuries, it can be treated operatively. Or if there's certain displaced displacement characteristics of the fracture on radiographs, so much varus valgus angulation, shortening, malrotation. Those are all also operative indications. So not a lot of controversy there. Well recognized that you can treat these fractures operatively. But what about the traditional closed humerus fracture with the radial nerve palsy? Well, when we're dealing with this, we have to realize, again, very little evidence. So let's see what we do know. So we know when there's a radial nerve palsy and the fracture is open, that's no problem. You should operate because the data is very clear on that. There's a few limited case series that show a consistently high level of an associated radial nerve palsy with an open fracture. So there's not much controversy there. Similarly, complex fractures. So for most of us, that usually consists of gunshot fractures, blast fractures, etc. It's reasonable to explore that when managing the fracture. But again, what about the closed fracture? Well, really, we have to think about this in a couple of different ways. So first of all, what's evolving right now are two camps. One's what I call the traditional camp. One is what I call the early exploration camp. So those in the with the traditional camp, they say, listen, if you operate early, you can potentially injure the nerve, you can potentially devascularize the nerve, you can potentially cause wound problems, you can potentially cause an infection, and frankly, these injuries rarely have a radial nerve problem that requires surgical intervention. So that's the traditional camp. The explore early camp argues, well, listen, these nerves can often be incarcerated within the fracture, and they do better when we liberate. These injuries may be associated with the radial nerve laceration, and we can argue what the frequency of that is. And we know that radial nerve injuries do better when we treat them early. And this camp would argue that if we definitively stabilize the fracture, so do plate and screw fixation of the fracture and imbue type 1 bony healing versus type 2 bony healing, it creates a better environment for radial nerve recovery in general. So these are the two camps. And really, like I said, it's the traditional camp that continues to rule the day. But let's look at this data a little bit more closely. A lot of this is based on data from the 60s, 70s, and 80s. So here's a paper by Sarmiento that's oft quoted. His series of 85 extra-articular distal third humerus fractures. He identified an 18% palsy rate, and he had 100% recovery rate, 100%. Every single patient recovered with non-operative treatment. This is oft quoted as the reason why not to treat these. However, there's been many other studies that have looked at this that have varying amounts of nerve recovery with non-operative treatment, spontaneous nerve recovery with non-operative treatment. The data primarily has a range that if you look at the series from 1990 and prior is about 70 to 100% of cases will recover spontaneously that have been published. And other conclusions from these studies are that, well, if you explore early, there's rarely a problem that you need to fix. And really, there's probably no difference in outcome when you explore them early versus just observe them. So this is the prevailing kind of perception. This is why it's a prevailing perception based on this data and experience. The Shao et al. Paper published in 2005 kind of solidifies that thought process. However, when you dissect the data, their findings are very interesting. First of all, they quoted an overall 88% radial nerve recovery rate. However, when you look at their subcategories, they say that those that are treated strictly non-operatively only had a 70% spontaneous radial nerve recovery rate, and those who were treated with early surgery, which is within 3 weeks of the injury, they had an 88% early operative recovery rate. Nonetheless, they said that expectant or observation for at least 2 to 3 months is reasonable before considering surgery. So the question is that really the way that we should be looking at this? But that's the current standard of care. And I want to be clear on that, particularly for the learners on this, is that the book answer, the test answer right now is observation for a closed humerus fracture with the radial nerve palsy based on the criteria and the evidence that I've just reviewed with you, with the only clear operative indication being a radial nerve palsy in the setting of a open humerus fracture. Those can be treated early surgically. But let's look at this data a little bit more. So we decided to tackle this and see can be better. And we did this from the perspective of this question that I posed to each of you. What would you want done for yourselves based on that data? And ask yourself, is only a potentially 70% spontaneous recovery rate with non-operative treatment acceptable as quoted by Shao? Is hoping that the nerve is not lacerated or hoping the nerve is not entrapped in fracture okay? Is waiting 2 to 3 months later while you've been disabled during this time to then later see if the nerve needs surgery, is that okay or not? And do we believe that a nerve repair done 3 months later is equivalent to a nerve repair done early? And these are the questions that we have to ask ourselves as the experts in this space and when we treat our patients and our colleagues. So we decided to look at this a little bit more closely and revisit this question. So we did what I call an updated systematic review, where we incorporated the data that was published through Shao, and then we added more data. And our series came up to actually 7,000 plus patients. There's been a lot of studies that have been published on this since the Shao paper was published. So we were able to add significantly more data. And not to be critical of the old data too much, but the data published more recently in the past 2 decades are of higher quality because of editors like Terrence, who are much more critical of the data being published. The data that we reviewed later was definitely of higher quality, but nonetheless, we incorporated all of the data so that we could give an honest review. And what did we find? Well, firstly, we found that the incidence was about what Shao had found at about 12%. And we looked at the recovery rates. We found that for all cases that are treated non-operatively, the spontaneous recovery was actually 77%, so actually better than Shao versus their 70%. We found that when surgery was performed early for a nerve palsy with the humerus fracture, there was a 90% recovery rate compared to 88%, so pretty equal. And we found that those who were operated late, so after 8 to 12 weeks because of lack of recovery, those nerves only recovered 68% of the time. So you have to ask yourself, is what's better for you and your patient? So would you want a 90% recovery rate when you operate early with a closed humerus fracture with the radial nerve palsy, or would you want a 77% recovery with non-operative treatment, or a 68% recovery with a late operative intervention? That's how we have to think about this data today. And everyone on this are A students, and I know everyone on this will want a 90 versus a 77. I wouldn't want to bring a C grade to my parents, I would tell you that much. So let's look at this a little bit more. So there's a couple other interesting findings that we had in the paper that I want to share with you. One was the type of nerve injury. So if you look at all comers in this paper, all studies that provided data on the findings of the nerve upon exploration for whatever time that they were explored, 64% were found to be completely in continuity, so consistent with our experience. A majority are traction injuries or contusions. However, 26% were found to be incarcerated, and 10% were found to be lacerated, so ultimately yielding a 36% incidence of an operative nerve lesion. And again, we're all nerve surgeons on this call. We know that nerve recovery is time sensitive, so we have 36 operative nerve lesions. So really, this is kind of what we came up with, is to ask ourselves, what's a better percentage we want to offer our patients? So let's talk it from a discussion perspective a little bit, and kind of move away from the data and just talk about what we understand about nerve surgery. We know the potential advantages of exploring a radial nerve in the setting of a palsy is as follows. One, we can define the extent of nerve injury. We can find if it's contused, if it's lacerated, it's entrapped. If it is entrapped, which commonly happens, I had a case just last week of the same issue, radial nerve palsy. The nerve was sitting inside the butterfly fragment of a common neurohumerus shaft fracture. So we were able to liberate that nerve. There's cases where the nerve can be lacerated. You can primarily repair the nerve versus doing some kind of reconstructive procedure like this, grafting in a late case. You can simultaneously fix the fracture while addressing the nerve, and that creates a better environment potentially for the radial nerve to recover once the bone is stabilized and you have type 1 healing and less callus formation. Once the fracture is repaired, you can mobilize the arm sooner. There's no fracture brace. You can mobilize the shoulder, the elbow, get the rehab for the hand started right away. And then you can avoid a harder surgery later. There's many nerve surgeons on this call, and we've all probably been in this situation at least one time, where you were asked by a colleague to, hey, the radial nerve is not working and this patient's been 3 months, and you get this x-ray and you see this huge ball of callus, and you know that the nerve is somewhere in that callus, and you know that this is going to be a daunting intervention, and likely the nerve is not going to be salvageable. So doing these cases early, you can avoid these incarcerated nerves within the callus, and then also retracted nerve endings. So there is advantages beyond that. What the evidence tells us, there's some practical advantages as nerve surgeon and those who treat nerve injuries to address these directly early. So in summary, what do we know so far? So again, I always want to be honest in terms of what the standard of care is. The standard of care currently remains the same, where that the current surgical indication for early operative fracture repair in the setting of radial nerve palsy remains displaced fractures, open fractures, complex fractures. The current standard of care is that we should observe a closed humerus fracture with the radial nerve palsy for 2 to 3 months. However, I think that it's time for us to revisit this And the fact that we were able to publish this in the Journal of the American Academy of Orthopedic Surgeons, I think speaks to that recognition that this problem needs to be revisited, and that perhaps we should be being a little bit more aggressive in the management of this because of the difference in outcomes and the issues with delays and the benefits of early intervention. So with that, I'll pause and I'll thank everyone. I'm happy to take any questions. I'll also unshare my screen.
Thank you, Dr. Asif. You have made it very clear about the presentation of humerus fractures with nerve palsy. All I could remember is the numerical value: 3 weeks, 90 versus 77, 90 versus 68. Absolutely very useful. We have a lot of questions from the participants. Before going to the questions, we have the special guest for this journal club. He is the Secretary General of our Association of Orthopedic States. We have the South Indian Orthopedic Association States. We have combined together to form a society and a great unit. We work together in the South India. So we have the Secretary General with us, Dr. Anil Kutty, who's here with us, and he joined us in the very late moment because of my late invitation. I'm very thankful, Dr. Anil Kutty, to join us. And we'd like to have you here among this meeting. Yeah, Anil Kutty, please.
Well, I say sorry. Sure. Hello? Can you hear me?
Sorry, yeah. Yeah, please go ahead, please go ahead.
Okay. This is the first time a journal is having a webinar, and great speakers from all over the world has been brought. As if your presentation was great, I was enlightened with the present thinking process because I couldn't, and Peter also, that was great presentation. We are all taught of waiting for the nerve injury and then to tackle as if. So it's a new thinking process for us all. Thank you, and I wish all this program and the future programs all the best. I'm happy to join you in all these programs. Thank you.
Thank you, Dr. Anil Kutty. We have a very good number of questions here. We will start with the questions. Probably the presenters can take the questions. We'll start with Dr. Narendra Seni from India. He said, he asked, beyond the clinical examination, are there any investigations you recommend to document the nerve injury, especially in pediatric upper limb?
Well, I responded to him and said that early on, no. But I think that if your nerve palsy is not getting better by 3 to 6 months, then I may recommend nerve studies at that point. I think the data pretty clearly shows that early on in the process, they are probably not indicated. But if your nerve injury is not getting better, then you'd have to start thinking about the next steps. And I think I responded to someone else saying that, what would those next steps be? Would you repair it? Well, I think you would explore it if the nerve is in discontinuity or just seems very ragged or compressed. Then you still have all your options open for nerve transfers, which become much more predominant now, or even doing some type of neural or nerve grafting. But I think that's such a rare occurrence that you're probably doing more harm than good by exploring a lot of these early, just because the vast majority really do seem to recover on their own.
Thank you. Please bear with me because I'm repeating the questions which have been answered in the chat box, because this is being live in the YouTube. So most of the people, almost more than 200 people are there in the YouTube watching live. It will be more useful for them to have the questions and then the answers there. Please bear with me if I'm repeating the same questions in the chat.
Dr. Jérôme, can I make a comment?
Yeah, go ahead.
Yeah, so in the adult situation where I take care of more adults, nerve studies are actually, limited in terms of what they can give you in terms of information. The reality is that, you know a lot from just the physical examination. And so I will use nerve studies when things have not progressed in 3 months, just to document any subtle changes in the nerve. So sometimes you can pick up improved conduction velocities or subtle motor changes, and you can't detect grossly on exam. And usually I like to document the status of the nerve before I go in and do surgery. So, but in general, sometimes like this, the nerve studies come back and say nerve is severely like injured, and then that doesn't tell you anything. But subtle changes it might be able to tell you. But the reality is that, you know, when I take care of plexus patients and when I take care of like nerve injury patients, I really rely on my physical exam. I do order nerve studies, but they more for a little bit of documentation and also for subtle changes. But the reality is, I think the physical exam is your best bet.
The other question from B. Daniel to Dr. Asif. How far would you explore the radial lobe primarily? Do you have a medial or a lateral incision, and how far you go proximally or distally? Question from Dr. B. Daniel to Dr. Asif.
Sure. Typically with these injuries, the fracture is going to be in the middle or distal third of the humerus. So if I'm dealing with, let's say, a distal third humerus fracture, I typically go straight posterior and I do a lateral paratricipital approach. And I will visualize the nerve across the zone of injury. Once we're past the zone of injury, I don't have to go further. That's where the problem is going to be. If it's a mid-shaft humerus fracture, I can still go posteriorly, or sometimes if I feel like it's going to be a little bit more of a proximal work in terms of getting the fracture repaired, I'll do a lateral or anterolateral approach, which can then be developed into a delta pec proximally if need be. And similarly, it's all about visualizing the nerve across the zone of injury, across the fracture.
Yeah, thank you. The other question is, even in a case where you don't have an apparent ulnar nerve involvement, where ulnar nerve may not be damaged, but then patients are having, ulnar nerve sensory hyposthesia or hyperalgesia for almost 6 months post surgery. Again, a question from Dr. Narendra Sen. He said, if you don't have a motor deficit but only a sensory problem, would you still go and intervene? And what is your take on this? How do you proceed?
I don't know if that's for Peter or for an I, but I'm gonna comment on that as well, if that's okay, if Peter doesn't mind. So as Peter mentioned, we looked at this problem and we looked at the papers that are out there. And firstly, it's a very broad range of incidence of ulnar neuropathy from distal humerus fractures, which in my own interpretation of the published data indicates inconsistency of documentation of nerve function. When we did our own case series that we had published prior to that meta-analysis or systematic review that Peter had shared, we found an incidence of about, I want to say it was 37 or 35%. It was quite high. We were critical of our cases in terms of ulnar nerve function. So much so that I make a point to tell every patient when I'm dealing with the distal humerus fracture to let them know that there's a high incidence of ulnar nerve dysfunction with these injuries. And the reason for that is multifold. The ulnar neuropathy can occur from the initial trauma. The ulnar neuropathy can occur from the surgical intervention, and the ulnar neuropathy can occur from the prolonged postoperative edema and stiffness that ensues. So we all know that if the elbow is kept in a flexed posture for a long time, it will lend itself to neuropathy. Then you add the edema, then you add the contusion, then you add the bruising. Limited motion from fracture recovery, all those things lend themselves to ulnar neuropathy. So what the fundamental cause of the ulnar neuropathy is I think multiple, and we don't always know that. I think a laceration of the ulnar nerve is extremely uncommon. Unlike the radial nerve, I think laceration of the ulnar nerve is extremely uncommon, but neuropathy is high. Now I say all this because we need to know that going in terms of management of those injuries. And we need to have a game plan. So if they develop neuropathy, what are you going to do? So earlier in my practice, I would always transpose ulnar nerves when I did a distal humerus fracture. Now I don't, because we've also done a review looking at when they're transposed versus left in situ, what's the difference in neuropathy? And there's really no difference. So I actually leave the nerve in its native position, unless it will not stay, but I leave the nerve otherwise in its native position because I want to have the option to transpose that nerve if that patient ultimately does develop a neuropathy. Since there's no benefit that's been proven in the literature or in my own hands that primary transposition is better than doing an inside to release and fixation of the fracture. And then I can then move on that. The last thing I'll say to that point is that it's amazing to me how quickly people weaken and atrophy with ulnar neuropathy. I've never understood how they can so quickly deteriorate. So to the point of the main point of the question, if I start to see weakening and any muscular atrophy, I will move on that. I don't care if they don't have sensory symptoms. Treating a lot of ulnar nerve dysfunction, people have very variable symptoms from ulnar dysfunction. The most common is numbness, but some folks present with weakness, atrophy, a lack of dexterity. And once you lose that motor intrinsic function, it's not coming back. So my threshold to operate to try to decompress it and try to salvage it is low. And last comment I'll make is people don't do well with revision surgery of the ulnar nerve. So you have to prepare them for not a great prognosis. You'll say, I'm going to try to make it better, but I can't guarantee it's going to actually improve.
Also, when you do distal humerus fractures, so you're not releasing the nerve, or you're keeping it inside you throughout the case?
Yeah, so I've changed my technique. I'll send you a picture of this. And I learned this from Egelsetter at Maryland a few years back. It's a really cool technique, so I take no credit for it. So he'll do a regular release of the nerve posteriorly like we would do, right? And you expose the triceps and what have you. And this doesn't matter if you're doing an osteotomy or a tricep sparing where you split or use two windows. He'll then, on the medial to the ulnar nerve, he'll do a sharp elevation of the periosteum and raise that periosteum off the medial epicondyle from a midline to a medial position and elevate it with a soft tissue envelope. When we're done, we then put that periosteum down and then repair it to the triceps, and it actually brings the nerve back into the medial epicondyle. The difference is that when we do our transposition, we do a circumferential neurolysis of the nerve and release all the adventitial connections between the nerve and its surrounding. This is a true neuroplasty where you're doing just a release, like a neuroplasty of a cubital tunnel, and then leave all the posterior deep connection of the nerve to the soft tissue and elevate it as a sleeve.
So another comment for the patient who's had nerve symptoms. I mean, if a patient is reporting some sort of nerve symptoms in general, that's the nerve crying out for help. So we shouldn't ignore this. So even if their motor is in, if they're complaining about paresthesias, I think that's an important thing to act on. I mean, I use the same criteria when patients come see me for previous primary nerve decompressions, like carpal tunnel tunnel. And this, regardless of what the nerve study will say when I order a new one, if they tell me that their symptoms are worsening or recurring, then I will use that as an indication for a revision nerve decompression, because that's what, if they're, I mean, assuming the patient's not totally lying, which usually you don't, then their nerve is saying that something is wrong.
Yeah, thank you. The very common question from all the panel, the delegates, even though rare condition, maybe Dr. John can start with, and Dr. Peter and ASIF can finalize about this opinion. The Kirschner wire, use of Kirschner wire and supracondylar humerus. What do you do when it passes through the ulnar nerve or damages the ulnar nerve? Very rarely can also injure the other nerves. I have seen Kirschner wires injuring the median and the radial nerve. What is your current take? The recommendation? Probably you can start with Dr. Peter, then John, and then ASIF.
John, you can go first.
So it sounds like you're almost describing like a neuroma in situ. The K-wire goes through the ulnar nerve. The nerve is in continuity, but clearly there's an abnormality, and you've got some either sensory or motor changes. I usually base on what is out, meaning like, is it sensory that's out or is it motor that's out, and kind of base some of the treatment there. I mean, I think that I would probably pull in the microscope. I would do like a perineural dissection and kind of see if I can figure out which fascicles are involved. If there is some motor intact, I would probably go down and do an AIN supercharge, because I'm not sure that resecting that when there is some motor intact is beneficial. I think if it was sensory only, and depending on how large the neuroma was, I would probably, like I said, dissect the sensory fascicles and then graft it.
Yeah, thank you.
I mean, the neuroma in situs are very difficult. So really depends on what their patient's deficits are, and like what you're at risk of losing. So I probably use a similar approach to that John has, and then really decide, am I going to make more, create more damage than it's worth? Like, for example, if their intrinsics are in, am I going to risk like losing those? If it's just a sensory deficit, I would say maybe I would explore it, but really think about whether I should do a resection and then the grafting, because it probably will not do very well postoperatively. So.
Yeah, I have very little to add. I would agree with both that. I think if it's just a limited deficit, I would not resect and graft. If it's a complete deficit, then I would resect and graft. And in a child, you would expect a superior outcome than in an adult. So I think it's worthwhile in that situation, particularly before atrophy sets in.
Yeah, thank you. Other question to all the three panelists. The radial, median, and ulnar nerve has been completely covered about, in the humerus fractures. To all these panelists, what do you think, which criteria has a worst prognosis? Maybe clinical, can be electrophysiological. According to you, for particular nerves, which aspect do you think has a worst prognosis? When do you intervene, and what approach? Particularly for the median nerve, the radial nerve, and the ulnar nerve. These are the selective questions from the delegates I put together so that each can speak about their nerves.
First, I'll make it easier for me.
Yeah.
I think the worst prognostic factor for me is a crush injury, because the length of the injury and the zone of injury is so large. And then even after you do a really good job treating that, it often scars back into the bed, and that can make it really difficult. So, I mean, you talked about electrophysiologic changes. I mean, I think nerve tests have their place, but I actually really think that the mechanism of injury and the zone of injury is probably the biggest prognostic factor in my world.
I think a high ulnar nerve injury is the worst injury to have in general. So if we have a radial nerve injury, if they lose like sensory, then just the back of the hand, I think we're okay. And then depending on what you believe in, whether you believe in nerve transfers for motor deficits from radial nerve palsy or tendon transfers, I personally like tendon transfers. And so you have a good backup plan in case your motor does not come back after a PIN injury. So I think that's good. But the problem is that I've only done a couple of the tendon transfers for clawing, and they all are terrible. So you can't make it better. So if you have an ulnar nerve injury, it's bad. In my hands, the AN to ulnar motor is not very good. I would maybe do an end to side, but I would not do an end to end. Maybe it adds some benefit, but I've never had someone have great results from there. So that's like the worst injury, I would say.
A couple comments. So in the setting of a radial nerve palsy with a humerus fracture, the worst injuries actually are typically bad traction injuries or crush injuries, because you don't know at the time of your initial surgery what you can do beyond just looking at it. They have to declare themselves later. So those are those folks, like I said. So if you in the talk, there's a 90% recovery rate of radial nerves with early operations. So there's 10% that still don't recover, right? So why do they recover? There's probably going to be either a traction injury or a crush injury, resulting in neuroma and continuity. And there's not much to do primarily. So then you're looking at reconstructive options, and we can talk about that. And they're both in the form of late tendon transfers or nerve transfers. For myself, I'm still using tendon transfers for those who don't recover. I know there's some work and some techniques out for radial nerve transfers for these problems. I'll admit to you that I have no experience with them yet. I'm hoping to learn more about them and see some published work on them, particularly with some of the participants today. Hopefully they're publishing their experience with them, that if they're doing nerve transfers for radial nerve palsy, we could all really learn from those. So I would do tendon transfers. If I'm doing a reconstructive case, which often happens, so you have a patient treated elsewhere, they didn't recover, and then they're sent to you 3-6 months later, which is not uncommon for us as reconstructive surgeons. In that situation, what I'll do is I will do the nerve exploration, and I'll do a simultaneous internal splint where I'll do a PT to ECR transfer primarily. I just do that transfer because it's not that invasive. It's not hard to do, and it's easy to rehab, and it immediately puts the hand at a mechanical advantage. So even though the fingers aren't working, the hand's at a mechanical advantage, and they can still get their hands and thumbs around things to use it. And then I view it as a staged transfer. So if my nerve procedure didn't work, so another 6 to 12 weeks go by and it's not getting better, well, then I'll proceed with the second stage of transfers where I'll do the finger transfers and thumb transfer as well. But if the nerve does come back, my internal stem transfer, PT, ECRB transfers, there's no harm in it, and I didn't do any damage or burn any bridges. Last comment is someone asked about the technique to use. So if you're doing any humerus fracture in the setting of a radial nerve palsy, it should be open reduction internal fixation with plate and screw construct. You shouldn't really be doing an IM nail unless you're doing exploration of the nerve, making sure the nerve is not in the fracture site, and then passing the IM nail. That's fine. But a closed IM nailing of a humerus fracture in the setting of a radial nerve is a dangerous proposition, because you don't know where that nerve is, and it's conceivable, particularly in a common nerve fracture, that nerve could potentially be in the fracture site, or as you're passing the nail and the guide wire and you're taking multiple stabs down the canal of the humerus, you could then iatrogenically injure the nerve. So radial nerve palsy in the setting of a humerus fracture, I think, is a relative, if not absolute, contraindication to closed intramedullary nailing.
And then, Jérôme, and so in terms of median nerve palsies, you know, the bailout in that situation, obviously, as you guys know, so there are sensory transfers from the ulnar nerve that we can restore some sensation. I actually haven't done those. I've yet to do one of those. And then for the motor deficits, for the AIN, we can just do side-to-side transfers of the FDP of the mid ring and small to the index and like middle, and then side to side, and then like a Briga radialis to FPL to restore that. Or if you don't, and then if you don't do the sensory, you know, the patient can visually just look at their hand. Obviously, it's not ideal in terms of like sensation. So I mean, those are still good bailouts for median nerve injuries. So for the median radial, we have some good bailouts. Obviously, ulnar nerve, the tendon transfers don't seem to do great for the clawing and intrinsic function.
Thank you. One of the article I read from the PRS in the recent is the 5 surgeries which really work in hand and upper limb. One of the surgeries is the tendon transfer for radial nerve injury, radial nerve palsy. They really do work well in the hands of orthopedic surgeons. Having said that, we also read about the nerve transfers by Dr. Susan McKinnon, where the distal nerve transfers for radial nerve palsy really works in her hand. What's your thought on it? Even though we prefer tendon transfer, what is the current concept about the distal nerve transfers for radial nerve palsy?
I would say, Terrence, that we're early in the curve of understanding nerve transfers. I think that there's a lot of interesting things occurring in the world of nerve injuries, between PEG fusions for early nerve repair and nerve transfers for reconstructive. I think we're at the precipice of really being able to treat these injuries a little bit better, because frankly, we're not very good at treating nerve injuries as it stands. We accept a lot of dysfunction and disability associated with this. So there's a lot of room for improvement. Listen, tendon transfers are tried and true. I consider myself a very average tendon transfer surgeon. The techniques I learned was actually spending time in India with Dr. Joshua in Bihar and the Leprosy Mission Trust. That really helped my ability to do tendon transfers reasonably effectively, but not nearly as well as many of my colleagues in India can do them. But I hope that the nerve transfers will replace that. Obviously, they're time sensitive. There's a window, 3 to 12 months to do them before there's motor end plate loss and atrophy distally. The techniques need to be worked out, etc. Right now, only a few centers are publishing on them, and that's a problem. We have to get more folks trying them. Anytime a new technique comes out, it has to be confirmed with other design surgeons or innovative surgeons to make sure that it really works in everyone's hands. I don't see that yet, but I'm really hopeful that it will.
So I would say so in a way, the tendon transfers versus nerve transfers, the tendon transfers is almost like a mechanical solution for the deficit, right? They're basically moving tendons and they're making do other like function, right? Mechanical function. The nerve transfer, in a way, a biologic approach to it. So I will tell you that I've done a number of nerve transfers, and I've gotten a muscle that's been paralyzed to actually fire, and it's a great feeling. But for the patient, if the motor strength is only 3 out of 5, it's not functional for them. So the problem is that nerve transfers can work, but they're not always reliable. And I've done them, and I've gotten function, but it's not clinically significant for the patient. So it's not helpful to them. So I will tell you all the nerve transfers. For example, my brachial plexus patients, I can tell them if they have an upper trunk injury, I can get their elbow to flex. The double fascicular transfer or the single fascicular transfer to go from the median nerve fascicle or the ulnar nerve fascicle to the muscocutaneous nerve to the biceps or brachialis, they work. I can get them elbow to flex. Can I get their shoulder to move up? Not always, because I've gotten the deltoid to come back from a radial nerve, medial triceps transfer to the axillary nerve. I've gotten the deltoid to function, but I can never get the suprascapular nerve to come back from a spinal accessory nerve transfer. It won't work. I don't know why, and no one exactly know why, and that's supported in the literature. It doesn't work. Under the distal transfers, some work and some don't. Again, I told you before, the AN to ulnar motor, I can't get it. It doesn't seem to work for my patients. McKinnon has great results, and other people have shown some good results. Though when I ask personally, like people at conferences, does that work for you? And it's I think it helps with decreasing clawing. I mean, part of the problem is that we have a very hard way of objectively evaluating ulnar nerve dysfunctions from a motor standpoint. You know, I've seen McKinnon do some things where like he draws on paper and sees how much abduction the patient does to like try to track its progress, but it's very hard. Like when the ulnar nerve is out, when the intrinsics are out, it's hard to like define how bad it is, right? So again, some nerve transfers work real well, and some they don't. And I've had it happen to myself.
Thank you. We've almost gone through all the questions. Probably we have a quick 30 seconds closing remark from all the panelists, and then probably we call it a day. We'll start with Dr. John.
Thanks again for the invite. It's an honor to be here and to talk with Dr. Tang and Dr. ILYAS. I think the beauty of working with kids is, as Dr. ILYAS mentioned, they have the best potential for nerve recovery. It's often the most heartbreaking when they get these bad injuries, but you know, if you're going to have to do grafting or nerve transfers or whatever you're going to do, these kids have the best recovery, and they're also the most adaptable too. I mean, I see a lot of congenital hand things. You see kids running around with 2 fingers on one hand, and they're more functional than some other kids that have 5. So that's the real beauty about taking care of kids.
Again, I want to thank you guys for the invite, and again, it was a pleasure to be with you all and to be able to talk to all the participants and the panelists and Dr. Jérôme. So I will end with basically really evaluating your patients closely and having detailed notes. A lot of upper extremity surgeons may not like document 2-point discrimination, so you may not find subtle changes, or if you're just seeing someone with a carpal tunnel or cubital tunnel, you don't document that preoperatively, and afterwards the patient like doesn't do well or they still complain, and you don't have that objective documentation, it really hurts your hurts that situation, you know. And so when patients complain, don't ignore them in terms of if they're having nerve symptoms.
Thank you.
Thank you. No, so first of all, thank you, Terrence, for having us. What you're doing on a monthly basis is really great to increase these discussions and sharing of ideas. And I want to thank John and Peter. I always learn a ton from these guys. My comment is just a plea to my colleagues across the world. Particularly, there's a lot of folks from India on this call. I really ask you guys to look at your patient experience and publish on them, particularly academic surgeons on the call. You guys have something we don't have. You have a larger patient population. and you have more complex injuries than we see nowadays. And that's a product of the population size of India, and the work environment is very different from the States. And you have a really large base of patients to study, and we can all learn from. And today we lean on a lot of level 4, level 5 data to make conclusions. And I want to show you that that's not very good. And as academic surgeons, we have to be critical of the data that we're using to guide us. And you guys can help in that process by sharing your experiences and then creating comparative studies, cohort studies, randomized studies, whatever it is, to look at these problems, and then particularly these newer techniques like the nerve transfers and what have you. So just a plea to contribute, because I know you guys can have the ability, and more importantly, have the patient population. So Terrence, thank you very much. Peter, John, thank you very much.
Yeah, thank you. Quick 10 seconds from our the other panelist. Dr. Karthikeyan, Professor Karthikeyan is there.
You may be on mute.
Yes, thank you. Thank you, Terrence. It was great. I mean, it was interesting. And as ASIF said, we've got a big database of patients, and we need to publish our results. Patients. And the important thing, as he said, we need to document it and publish it. I think we should do it, and it will be a great impetus to learn also. Thank you so much, Terrence, and thank you all the panelists.
Sure. Thanks for joining us, sir. We will definitely, have a great, concept to publish is to cherish. I mean, that's really the need of our younger surgeons in India. Thank you very much, sir. Thank you for joining us. Dr. Arun?
It's been a great pleasure to watch all these guys speak about all the nerve injuries. And Terrence, I congratulate you for doing a wonderful job in thinking about all these topics, getting all these stalwarts to speak, and it's been great watching you guys. Thank you.
Thank you. Always amazing. Dr. Anim?
Sorry.
Yeah,
Can you hear me?
Yeah, go ahead.
Yeah. It's excellent. Excellent program and excellent speakers. Hands off to you for organizing this from all over the world. And that everybody also great. Looking on to the next program, Terrence. Great show.
Sure. Thank you. Thank you all the panelists who have been here on the Saturday. Dr. John, amazing about the median nerve injury. You said children, they have definitely a good recovery pattern. Wait and don't intervene before any other fractures, the supracondylar fractures. Intervene when you have any associated nerve injuries. That's amazing. And Dr. Peter Tang, he said, no, something is problem, nerve is crying. Amazing. We will take that message. There's some problem, nerve will not have any, presentation, either sensory hypoesthesia. So you need to intervene at the time. Watch carefully about the distal nerve transfers. And ASIF, amazing. The calculation is very good. It always remains in our mind. And one last plea, really we are very, committed to that. Thanks for the plea. Publish is to cherish. All this, that's it for today. Thank you one and all for joining us and making this event a great show. It is nice and a great show. Thank you one and all. Have a safe day. Be safe and healthy. Thank you.
Thank you. Thank you.
Thank you, sir.